Women are not just slightly smaller men. This might seem obvious, but it's something historically not well recognised in medical research, particularly in cardiology. In fact, in 1970, women represented just 9% of participants in clinical trials. This means that many of our cardiovascular treatments are based on data in middle-aged men, and much of our understanding of cardiovascular diseases is limited to those phenotypes seen predominantly in men. This would be okay if women exhibited exactly the same cardiovascular pathology, but they don't. This applies to a range of cardiovascular diseases, but what my PhD focuses on is the sex difference in heart failure phenotype. There are two main types of heart failure classified according to whether the percentage of blood ejected from the heart with each beat is normal or not. Heart failure with reduced ejection fraction, or HFrEF, is where the heart becomes thinned and stretched, is able to fill with blood but not able to pump it out effectively. There have been decades of high-quality research into HFrEF, and as a result there are a number of mortality-adjusting treatments for this condition and these patients, most of whom are men. Heart failure with preserved ejection fraction, or HFpEF, is where the heart becomes thickened and stiffened, and although it still is managing to pump quite well, it doesn't fill with blood in the first place. It is similarly debilitating to HFrEF, although there are no mortality-adjusting treatments for this condition, and most of these patients are women. This suggests that women may be predisposed to HFpEF. Understanding why may enable us to further appreciate the likely heterogeneous causes and phenotypes of HFpEF. The first thing is, how do women's hearts differ? We know that with ageing, women see more stiffening of their heart, but I looked into what exercise does to the pressures in the heart and saw that with exercise, women's left heart pressures soar far higher than those of men. This causes shortness of breath and may predispose them to HFpEF. However, not all women get HFpEF, therefore there must be precipitating factors. I looked into the role of iron deficiency, which is far more common in women, and found that it prolongs hospital stay in HFpEF patients, making it a likely contributor. Women also have stronger immune systems and higher levels of inflammation, and HFpEF has clear inflammatory origins. I'm investigating whether this may be mediated by sex differences in the intestinal microbiome. Another obvious cause of sex differences could be pregnancy and its complications such as preeclampsia. These events may contribute to stiffening and inflammation of the heart and further push women towards a HFpEF phenotype. These factors may be used to highlight women who are at higher risk of HFpEF and mitigate further risk factors such as hypertension. Understanding and preventing this debilitating disease, along with identifying novel therapeutic targets, is important and desperately needed, as is dedicating more research to cardiovascular diseases in women, because we're not just small men. Thank you.